Researchers ran a clinical trial where patients taking semaglutide showed liver disease improvement, even with minimal weight loss. That sentence should not be possible. The entire medical world assumed this drug worked because it made people thinner. That assumption just collapsed. By the end of this video, you will understand exactly how Ozempic is rewriting organ medicine, and why 1 in 3 Americans may need to have a conversation with their doctor that they have never had before. This video is not about weight loss. It is not about celebrity drug culture or insurance battles or appetite suppression. This is about a specific organ, your liver, and a clinical trial that found a drug repairing it through a mechanism nobody fully predicted. We are going to walk through what the trial found, what it means for the 100 million Americans currently walking around with a liver condition most of them do not know they have, and what the one question is that you should be asking at your next doctor's appointment. To understand why this trial is such a big deal, you need to know what we are actually talking about. The condition is called MASLD, Metabolic Dysfunction Associated Steatotic Liver Disease. You may know it as non-alcoholic fatty liver disease. It is exactly what it sounds like. Fat accumulates inside liver cells, slowly impairing the organ's ability to filter toxins, regulate blood sugar, and produce the proteins your blood needs to clot. In its early stages, there are almost no symptoms. You feel fine, but left unchecked, it progresses in millions of people to scarring, then cirrhosis, then liver failure. And here is the number that frames everything that follows. Roughly 1 in 3 American adults has this condition right now. Most have never been told. There is no FDA-approved pill for it. Until very recently, the only real intervention was telling patients to lose weight and exercise more. Advice that, as most of us know from lived experience, is easier said than done. So here is what actually happened in the trial. A major randomized controlled trial tested semaglutide specifically on patients with MASH. This is where scarring actively forms. The results were striking. Patients taking semaglutide showed significant improvement in liver inflammation and a reduction in liver scarring, what doctors call fibrosis, compared to patients taking a placebo. That part was expected. But researchers also separated out a subgroup, patients who lost less than 5% of their body weight during the trial. Clinically, that is almost nothing, barely a rounding error on the scale. And in that subgroup, the people who essentially did not lose weight, the liver improvements still happened. Inflammation went down, scarring slowed or reversed. The drug was doing something to the liver directly, independently of the weight it was or was not removing from the body. If you have ever been told that Ozempic only works through weight loss, that it is just a very effective diet tool, this is the moment that story ends. The implication for you is direct. If you have fatty liver disease and you have ruled out this class of drugs because you do not want or need to lose weight, that reasoning just became medically outdated. The liver has over 500 known functions. It processes everything you eat, drink, and breathe. And until this trial, no drug had ever been approved to directly repair it when fat accumulation begins destroying it. Think about that. So if it is not weight loss doing the heavy lifting here, what is? This is where the biology gets genuinely fascinating. Semaglutide is a GLP-1 receptor agonist. GLP-1 stands for glucagon-like peptide 1. It is a hormone your gut naturally releases when you eat, and it does several things. It tells your pancreas to release insulin, it slows how fast your stomach empties, and it signals your brain that you are full. That is the weight loss mechanism most people have heard about. But GLP-1 receptors, the docking stations this molecule attaches to, exist all over the body, including in the liver. When semaglutide activates those liver receptors, researchers now believe it directly reduces fat accumulation inside liver cells, suppresses inflammatory signaling, the process that drives the scarring, and may improve how efficiently liver cells process lipids, which are fats. It is acting like a direct anti-inflammatory and fat-clearing signal inside the organ itself, separate from anything happening on the scale. This is a mechanistic shift. The drug is not just helping people eat less so their liver gets less incoming fat. It is talking directly to liver cells and telling them to calm the inflammatory response down. This distinction matters enormously for how doctors will prescribe it and for which patients will be eligible to receive it going forward. Here is something most people do not realize. Liver disease kills more people globally each year than breast cancer or colorectal cancer, but it gets a fraction of the research funding and almost none of the public awareness. That gap is about to close, fast. Now let us make this personal because the scale of who this affects is genuinely underappreciated. MASLD is not a disease of people who drink too much or eat fast food every day. Those are risk factors, but the condition is fundamentally tied to metabolic health, blood sugar regulation, insulin sensitivity, triglyceride levels, and metabolic dysfunction in America is essentially epidemic. If you are over 40, if you have type 2 diabetes or prediabetes, if you have been told your triglycerides are elevated, if you carry significant weight around your midsection, you are in a high-risk category for fatty liver disease right now, regardless of your other lifestyle choices. The condition is also dramatically underdiagnosed because routine blood panels do not catch it. A standard liver enzyme test, the ALT and AST numbers you might see on a blood panel, can look completely normal even when significant fat accumulation is occurring. The only reliable way to know your liver's true condition is an imaging scan, usually an ultrasound or a specialized MRI or a biopsy. Most people never get those unless a doctor has a specific reason to order them. What this means for you in practical terms, if you have any of those metabolic risk factors and you have never specifically had your liver assessed beyond a standard blood panel, you may be carrying a condition that a doctor has never named for you. That is worth one direct conversation at your next annual physical. Semaglutide costs over $900 a month without insurance. But treating end-stage liver disease, cirrhosis, liver failure, can run into hundreds of thousands of dollars over a patient's lifetime. The economics of early intervention here are not even close. Here is where we close the loop opened at the beginning of this video. The reason the clinical finding matters beyond the science is what it does to the regulatory and prescribing landscape, and that is where your life gets directly affected. The FDA has already granted Semaglutide a fast-track designation for liver disease indications, meaning regulators are actively moving toward a formal approval for this specific use. When that approval comes through, and some analysts project approval could occur within the next 1 to 2 years, it changes two things immediately. First, insurance coverage. Right now, many insurers refuse to cover GLP-1 drugs for patients who do not meet specific weight-based thresholds. A BMI cutoff, for instance. A liver disease indication would create a separate medical pathway. A patient with MASH who does not qualify for weight loss coverage could qualify under a liver disease diagnosis. For millions of Americans, a liver disease indication could potentially open a pathway to insurance coverage. Second, it changes how primary care physicians approach the conversation. Right now, most general practitioners only discuss GLP-1 drugs in the context of diabetes management or obesity. When a liver disease indication exists, a hepatologist, a liver specialist, has direct grounds to prescribe it. That means a whole new category of specialist is now in the conversation, and patients who have never been offered this drug may start hearing about it for the first time from their gastroenterologist or their liver clinic. The actionable step is simple. If you have any of the risk factors we covered, metabolic syndrome, type 2 diabetes, elevated triglycerides, or a family history of liver disease, ask your doctor directly about your liver health and whether a GLP-1 receptor agonist is worth discussing. You do not have to wait for the FDA. The trial data exists now. The conversation can happen now. Here is what we want to know from you. Did you know that fatty liver disease affects 1 in 3 American adults before watching this video? And have you ever had your liver specifically assessed beyond a standard blood panel? Drop your answer in the comments. And if you know someone with type 2 diabetes, prediabetes, or metabolic syndrome, this is one of those videos worth sending directly to them. If this video gave you something you did not know an hour ago, subscribe to Trends Daily. Next, we are covering the drug pricing executive order that just changed what Americans will pay for insulin and other biologics starting this year, including whether GLP-1 drugs are on that list. That video goes up this week. Hit the bell so you do not miss it. Something just happened in the world. Here is what it actually means for you.